That's fine?
Yes, it is good to go.
Okay. So we'll first see the definition of this particular topic, and then just go through the 4 cardinal principles. And, a hot topic that is very important for us when we deal with terminal illnesses, and something which bothers us a lot, and that is euthanasia. So it is, it's a basic moral code of behavior on the part of the professional, whether he's a nurse or a doctor or any other member of the palliative care team, or the medical team per se. The ethical principles are generally, a set of principles which, in a moral account, should function as an analytical framework that expresses the general values underlying the common morality. So these set of principles generally, guard us, generally guide us, and keep us in a circle of protection when we practice medicine or practice palliative care. So the ethics of palliative care are similar to those of medicine in general. But having said this, doctors always have a dual responsibility. I would say, is first to relieve suffering, and of course then preserve life. And when we say preserve life, when it is at the end of life, the relief of suffering is becomes more important, as we understand and we accept the fact that the preservation of life may not be possible at one point of time. So the 4 cardinal principles as applied to palliative care practice are patient autonomy, beneficence, non-maleficence, and justice. Regarding the autonomy, the questions that we are faced with are, what does the patient want? The patient say on the situation or the treatment or the goals have to be very clear. And at the same time, as in palliative care, we take the family as another unit, which also becomes a part of the whole treating team. We want to know whether the family understands what the patient wants. So that is about patient autonomy. Secondly, it is beneficence, which is literally will our initiatives or our interactions or any kind of intervention is going to benefit the patient or not. Non-maleficence, will it harm the patient? For any kind of intervention that we do, for any kind of decision that we take, is it going to harm the patient? And we should be wary about that. And last but not the least, the important one is justice, because at any point of time in India, and maybe in many other countries also, we have to work in resource poor settings. So we need to justify whether utilizing resources for one particular patient, is that actually depriving some other patient of his own rights and principles of medical ethics or palliative care ethics. So why do we have to discuss about ethics at all? What is that wants us into a situation where we are confused? So those situations are actually called ethical dilemma, and a kind of a conflict of moral principles occurring when a person faces certain situations where adhering to one particular principle might result in the violation of the other. To properly understand this particular situation, let us go through some examples. Now from here, I would request everyone who's here to please give their inputs either through the chat box or you can talk also, but has to be interactive session from here onwards. So this is a patient. You can see on the right hand side, he has a jaw tumor with a orocutaneous fistula. He's an elderly gentleman and he has been in pain since quite some time. But the positive point for this patient is that this patient doesn't have any kind of distant metastasis of the disease. Now, the doctor wants to treat the patient, for which he needs to be given an NG tube or a feeding tube or a Ryle's tube. The point here is the patient is now refusing to take the Ryle's tube. So what is our stand? What should be done at this point of time when he's refusing for an NG tube? Can I have some responses, please?
You can unmute from your end or speak or give your suggestions on the chat.
Yeah. So anybody who can, so I can see some responses in the chat. So counsel the patient and party, motivating him to agree, counseling and consent, refusing for how long? Okay, counsel the patient and family again. If not, then start TPN. Okay, counseling, motivation to cater, depression, pain, medication. Okay, autonomy has to be respected. Yes. Find out why. Yes, very good. If the patient refuses, cannot place it. Yeah, counseling may help. Okay. So ask what are the fears. So absolutely. I mean, I completely agree. So you see, the ethical dilemma here is between doing good and the choice of the patient. By putting the NG tube, we want to do good to this patient. We want to give that benefit to the patient. But then we also have to be conscious about the choice of the patient, which is patient autonomy. So as rightly pointed out by many people here, the patient has to be involved in the decision making process of, because it's your body. I mean, this is my body. I want to know what is happening to my body. I want to know where it is going. I want to know what kind of medications I am receiving. And it is me who is going to actually give you that permission to, give that particular intervention for me, for my body. So patient autonomy is the right to have dignity, privacy, and confidentiality. It is the right to have the information, the right to make decisions. And last but not the least, the treatment decision has to come as an informed choice of the patient. So these are the four things that actually guides us to, take into consideration the autonomy of the patient. So in this particular patient, as one gentleman actually pointed out, we need to have a informed refusal. So what are those things that we need to check in informed refusal? Number one, you check the understanding of the patient. Does the patient understand what might happen, if we do not, if he doesn't take the Ryle's tube? Okay. What are the reasons or the fears, as has been pointed out? What are the fears of this patient? Why doesn't want to take the NG tube? Maybe he doesn't have money. Maybe he thinks that that is going to create another problem for him. They do not understand anatomy at all, so they might think that it's going inside the lungs. So there may be numerous factors, and we need to find out those reasons, and if possible we need to clear out those reasons if they are not if they're baseless, or to say, we need to counsel him or her, to actually come into a platform where we know properly what the understanding is now, after being, his fears are being removed, and, the proper information that we have given this patient about the NG tube insertion. And then after all this, if you see that the patient is still refusing, please go on supporting the patient, even if you do not agree with his decision. So this is autonomy for this patient. We need to have an informed refusal. And if the patient is refusing after all these checkpoints that we have underlined, you have to support the patient with the decision of the patient. Do not abandon the patient. Please do not, give him this, kind of blame him that, oh, so from now on, you are responsible for whatever happens. Do not blame him. Just tell him, I am with you. Do not worry. We'll see how to do. So there has been patients, whom I have seen, and I have come across, who refuse many things that are intended for their benefit. But at the same time, when they see that the doctor is actually on their side, by their side, even when they have refused the treatment, at one point or the other, they actually come back to the doctor saying that, okay, doctor, I think you were right in your decision, and I would actually like to, get this treatment done. So this is how you should handle the autonomy of a patient. This is another patient, and this is a 20-year-old boy with osteosarcoma of the lower end of the femur. This tumor has now grown and has landed up in multiple lung metastases with severe anemia. But the patient wants an amputation now. Okay, so the procedure is very risky because of the general condition and the anemia that he has. And you have actually explained all the risks to him, but he wants to go with the amputation. So what is your take on this particular patient?
Ma'am, why they have a thought on that question? We have a couple of questions coming in. I think we can take it all together at the end.
Okay, all right. Okay, we'll do that. Okay, so this is a dilemma between doing good and avoiding harm. So you want to avoid the harm by not amputating this tumor, the leg. Okay, and at the same time, you want to do you want to bring in the benefit of by not actually performing the surgery. So we need to find out, or we need to discuss with this patient about the chances of cure. Okay, with a large osteosarcoma, metastasis to the lungs, severe anemia, poor general condition, is this patient has any chance of cure at all? Okay, so this is a question that you will perhaps want to discuss with the patient or the patient party also. The question of survival after the amputation, is it likely? Are there any chances of survival, or what is the balance between death and occurring in the table itself while undergoing the surgery? And once perhaps even if we agree to amputate, and the amputation is done. He survived the amputation. But then will this amputation improve his condition? So, these particular questions you will need to ask this patient and then explain with, examples. This same patient, now with an advanced cancer is under your care, and the relatives have insisted that the issues of diagnosis and prognosis should not be discussed with him. So when you go to see him one day, when he's all alone, he asks you what is wrong with him. So this patient, it's a different case and he doesn't know what is wrong with him. And the relatives do not want you to tell him what is going on. So what will you tell him? Any responses? Are you going to tell him that he has cancer or he's going to die, or, so it is the right to deliberately mislead a person or to withhold information that a person is asking for at the insistence of the patient's relatives. Is it right to do that? So for me, this 20-year-old boy is an adult. 18 years is a voting age in India, and not really talking about voting age, I would consider every patient to have the right to information, the right kind of information, and especially when the person or the patient is asking for it. Okay. Now, when the patient's relatives are insisting not to give you that information, will it not be, deliberately misleading this person by saying that, oh, nothing has happened, don't worry, you're going to be all right? Are you not actually giving this person a false hope of survival? So these things, these dilemmas are extremely, extremely difficult to handle. But you must know, the difference between doing good, refraining yourself from doing harm, and then at the same time giving the right information at the right point of time. This is another example where a 50-year-old lady with carcinoma of the stomach has come to the hospital in a terminal state, right? And probably the terminality is because of internal bleeding. Her systolic BP is 50 millimeter of mercury and she's extremely restless. Will you give her parenteral midazolam, which may hasten death? Now, can we have answers for this particular? I would like to have some responses here. Okay, so there's somebody saying that we not give midazolam. Okay. Anybody else? Anyone else? Yes, maybe better drug would be fentanyl. Okay. All right. Resuscitate the patient. Okay. No, ma'am, we need to stabilize her first. Okay. Okay. Yes, after proper counseling. Try to save her. Okay. All right. So now the ethical dilemma is, will it be right to give some medication to a terminally ill person which may inadvertently hasten the person's death? This is the dilemma that we go through. If you see here, this lady is in a terminal state, okay? And there has been an internal bleeding. You have prognosticated this patient to be in the terminal stage, to be at the end of life stage because of some internal bleeding due to the serious carcinoma of the stomach. her BP is 50 millimeter of mercury, and if you see, she's very restless. Now you have to prioritize the problems of this patient. And when we prioritize in palliative care, you will first need to give relief of suffering. As you saw in the first slide, the doctors have dual responsibility. Number one being, to relieve the patient of suffering, and number two, to preserve life. But for a patient with cancer stomach in a terminal state, the preservation of life may not be possible. So we have to take care of the restlessness. And when you go through the end of life class in this particular course, you'll come to know that midazolam is the gold standard of treatment for terminal restlessness. Now, midazolam can also inadvertently hasten the death of this person. So will you actually think that I am killing this person? I do not think so. You should not think on those lines, because there is a principle of double effect. This principle says that a single act of having two possible forcing effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. So by giving midazolam, your intention is not to kill the person. Your intention is to relieve her of the restlessness that is going on. And restlessness is actually disturbing her from the core. So we as physicians, as palliative care physicians, we have to relieve this person of the restlessness. And we know that midazolam is the gold standard for that. But at the same time, we also understand that this patient may, die because of the midazolam. So you have to consider, the principle of double effect at this time when such ethical principles or ethical dilemmas are there. I'll give you another simple example of this principle. We are always using morphine. Oral morphine is the gold standard of treatment for chronic pain, severe chronic pain. Now, morphine causes severe constipation. Morphine also causes a lot of drowsiness when the patient is opioid naive. Morphine also causes dryness, and nausea and vomiting sometimes. Now, your intention of giving morphine to patients is to manage the pain. Okay. Now, if you think about nausea, vomiting, constipation from oral morphine, then you will never be able to manage the pain of this patient, because this patient may not get relief from the pain with any other drugs, the step 2 or the step 1 drugs. Okay. The patient will be morphine responsive because of the pain score that you have actually calculated. Now, you know that the harmful effect of constipation, of nausea or vomiting is not intended. Your intention is to take care of the pain. So you will have to treat this patient with morphine. And if you consider the side effects, then of course the side effects can be taken care by any other. Yes, somebody has raised a hand. I think Dr. Shivani.
Yeah, ma'am. Ma'am, sorry to interrupt, ma'am. Actually, I have a question regarding this. How the doctor will safeguard his himself, because in today's scenario, as the attendants or patients relatives, they are always after the doctors for medical negligence. So how a doctor should safeguard himself in those scenarios, because the intention, no one knows a doctor's intention in such cases, na, that we are doing this for good.
Absolutely. So I am going to talk about this in my next slide. But then, of course, let me tell you that palliative care physicians are bestowed with a very good virtue of great communication skills. Okay. And this is what is actually going to save you. No law can actually save you. Let me tell you this, because the laws are intermingled with one another. If it's said in Hindi, it is like ek taraf kuan and ek taraf khai. Okay, but you have to be in between, because for any case which is suppose for a terminally ill person, you will not actually discuss terminality at the point of terminality. You will have to discuss this beforehand, much before the patient will land up in this situation. Okay, so you will have to communicate this particular problem to the relatives. You'll have to make them undergo a lot of personal discussions along with your team. It is also not you only who will do this. You will have a team, your nurse who's part of the team, your social worker if you have one. If you are a solo practitioner, you may have the doctor who's actually referred this patient to you. So your prognostication and your communication skills have to be communicated to the patient and the caregivers, not at the point of terminality, but much beforehand. If you do not do that, if you think that, okay, jab time aayega bol denge, no, it is not like that. Right from the day one that you've got this patient, you know that the patient may not make it, in the next perhaps 2 weeks or 3 weeks. You'll have to have a family conversation. You'll have to have a, that is why, in the other case, in the second case where this 20-year-old boy wanted to know what is happening, it is important that we tell all our patients, encourage them to know their diagnosis. And let me tell you, in my 15 years of small career of palliative care, I have actually come across patients who are illiterate patients, belong to the lower socioeconomic strata of the society, but they're so intelligent that they know that they're dying. They would actually expect the doctor to tell this. Be honest with the patient. So this is where you can save yourself by actually conditioning the family and the patient to the terminality that is actually approaching. And this is going to save you. I'll encourage all of you to have multiple family discussion regarding the patient. This is very advantageous because of the fact that nobody would have actually discussed the disease of the patient, the condition of the patient, before you did that in so much detail. I generally prepare myself by going through the files, going through the reports, going through the whole history of the patient, because in India, palliative care would be a little late. The referrals would be a little late. If you're lucky enough, your oncologist or the treating physician would definitely involve you right from the day of point of diagnosis. But generally, you are called at the last moment, if I may say so. And that's where the other doctors start having cold feet, and they would want the whole situation to be transferred to somebody else. And that's where you have an important role to play. And even if you do not, even if you cannot do anything at this point, if I may say, like in terms of active interventions from as a doctor, your virtue is that you can actually bring in the whole family, discuss the matter, what has been happening, how it has proceeded to this particular point, and what is that they should be anticipate. And I tell you, they're going to appreciate you from the core of their heart. And nobody, in my career, I have never been, pulled out of the room and, manhandled, misbehaved. I have always had very good family interactions. I have had many patients who have actually died in a day or two also after getting a referral, but nobody has blamed me because I have been honest with them, honest with the whole system because as a doctor, you are also not in a position, and it will be unethical to actually blame on the oncologists that, oh, आपको बताया नहीं पहले ये, क्यों नहीं बताया, उनके तो बताना चाहिए था. No, you have to handle it all by yourself, and that is where your communication skills are your ammunition. Okay. So I hope I'm clear in this whole part, because when you do not have anything to do, when you don't have medications, when you know that the patient might actually go away in next 48 hours, the only thing that you can positively give this patient and the family is the art of giving them the right information, the chunks of information that are going to clarify what they are going to do in the next couple of days. Okay. All right. So I come to another example. So this is a 70-year-old gentleman with advanced carcinoma of the lung who had completed a course of radiotherapy and 2 courses of chemotherapy. Is brought to the casualty. He is drowsy, his pulse is feeble, systolic BP is 60, and breathing pattern is altered. The family, wants everything possible done for them, this patient. So what do we do in such a situation? Do we resuscitate and shift him to the ICU? Do we keep on going investigating? Do we actually look after the hemodynamic and ventilatory support? Are we also concerned about the hydration and nutrition? So there's something called the appropriate treatment in palliative care, not only in palliative care, in every, discipline of medicine. So we have to define our treatment, looking at the condition of the patient, the prognosis of the patient. If the patient is okay hemodynamically, or if the patient has a single chance of even carrying on for the next 6 months, then perhaps our treatment the appropriateness of our treatment will change. But if the patient has only 2 days left, that will also change the appropriateness. So the important thing that you need to understand is you have to be a master of prognosticating the patient's condition. If you cannot do that, you must take help of a senior who's seen such cases, seen these patients, and prognosticated very well. Prognostication itself is an important art. So the appropriate treatment means that treatment that does not provide net benefit to the patient, and the patient may ethically and legally be withdrawn, and the goal of medicine should shift to the palliation of symptoms. So here in this particular patient, he is already 74. He is advanced carcinoma of the lung. He's already completed radiotherapy, chemotherapy, and right now he's drowsy and he's feeble. He has a feeble pulse. His blood pressure is 60, and altered breathing pattern. All these clinical criteria, laid down in front of you. in my opinion, the prognostication is that this person is not going to live for another 24 hours. So for this particular patient, even if the family wants everything possible, which includes even ventilation, you need to talk to them about what might happen in case of ventilation, which is a futile, process for this particular patient. Okay, I'm not talking about somebody who's just had a road accident and has come to the ICU, and those are different patients. But for a patient who's already completed everything for advanced carcinoma of the lung, your prognostication will actually tell you that this person is not going to live for 24 hours. And this is the time where you will need to lay out everything honestly in front of this particular family. Tell this family that they will not be able to see the patient in the ICU if he is ventilated. Tell this patient family that their patient may not have the privilege to be surrounded by the family in the ICU, because he'll be ventilated, he'll be surrounded by strange people like the nurses whom he doesn't know. Even if he wants to signal something to the family, he will not be able to do that because the family is not going to be around. And you are sure that this patient is not going to make it for another 24 to 48 hours. So this is where the dilemmas of ethics for our patients and our situations, we need to have a proactive kind of a behavior, proactive kind of a action for every situation that we face. And that is definitely going to help the family, help the patient, and help the help you also, you as a doctor. So these are the key points of an appropriate treatment. We need to see the biological prospects of this patient, the therapeutic aim and benefits of each treatment that we do, the adverse effects of each treatment. Okay, if the family is actually pressing upon you to do a ventilation, tell them about the adverse effects. How is it futile? What is it actually going to do to the patient? And then the need of not prescribing a lingering death. Okay, so all these 4 points are important key points to delineate your appropriate treatment of this particular patient. Coming to the last ethical principle, this is justice, which means we need to balance the needs of the individual with that of the society. As in the very beginning, I told you that we need to appropriately justify the use of resources, the use of hospital beds. India is itself, an overpopulated country, a country with very less resources in terms of manpower, in terms of hospitals, in terms of hospital beds, in terms of medications also, affordable medications also. We need to understand, we need to justify why we have given this particular patient that particular treatment or whatever. So this is a patient. He's a 86-year-old journalist. He's a cancer lung with metastasis to the spine, the ribs, the sacrum. Now he has a son who has some sort of psychiatric disorder. He has 6 grandchildren. Now the goals of care for you as a doctor is to take care of the pain. The family actually sees at their finances whether they'll be able to keep on treating their patient in the hospital. There are 3 grandsons who are actually awaiting the Janevu Sanskar, which is a very costly affair. And you see that the breathlessness of this patient is increasing day by day, and he's actually collapsing in a certain step down pattern. So now our question is, are we going to put this patient in the ICU and look into certain aspects like the resources of the family? They have a psychiatric son, they have 6 grandsons, there is some kind of ritual that is pending. Is the family actually going to make use of the resources, divert these resources for this family, for this patient who is 86-year-old and going to die? At the same time, what about the hospital resources? Are we actually going to allocate the resources meant for this for other patients who might actually live longer or get cured of a certain disease or a certain condition? For example, a person who's young and just had a motorbike accident with a head injury is actually coming to the ICU. It doesn't find an ICU bed because you've already given this 86-year-old dying patient that ICU bed, and then this particular young fellow, he dies. So are we actually fairly allocating the hospital resources? And of course, the societies and the nation's resources. This brings us to something called euthanasia. So what are you going to do with these kind of patients? Are we actually going to kill them or euthanize them, as has been the hot topic in the last 20 to 35 years? So euthanasia per se is an act or a procedure in which someone takes active means such as a lethal injection to bring about someone's death. Okay, but having said this, allowing natural deaths to occur by withholding some of your actions and withdrawing a futile treatment. For example, when we say withholding, we are withholding ventilation for a dying patient. And when we say withdrawing, we are perhaps taking out the patient off the ventilator. So that's just an example that I'm giving. And this is allowing natural deaths to occur, and that does not amount to euthanasia. So, the point of putting the slide, this particular slide, is to make you understand that euthanasia cannot be passive. We are allowing the natural death process to occur for a person who's already dying, okay? And henceforth, when we are allowing that to happen, we are not euthanizing this person, right? But when we do euthanasia, it has to be something active, like giving a lethal injection, a mixture of maybe midazolam, morphine, and whatnot, to make the patient die. And that amounts to murder. It cannot be, giving some kind of benefit to the patient. We have actually, brought an end to this whole affair. It is bringing about someone's death, means you are actually murdering this patient. But when we are allowing natural death to occur, is not euthanasia. For example, where people are dying in villages, when I remember my grandfather, he was old and he was bedridden for around 2 weeks, and he never wanted to go to the hospital. And he said that, no, whatever happens, it will be in my home, and I want this puja to be done. I want everything to be settled before I go. And we saw him slowly collapsing, talking to people, giving them directions after what will happen, or what to do after he's not there. So we have allowed natural deaths to occur for my grandfather. This definitely does not mean that we have euthanized my grandfather. It is not like that. Okay. But if as a doctor, I had given some kind of injection to bring about his death, I know that after giving this injection, my grandfather will not live, is going to die. Then actually I am euthanizing my grandfather. And that is amounting to murder. And it cannot be passive. It has to be an active euthanasia. And there is nothing called active and passive euthanasia. Has to be euthanasia is itself a term. Active and passive are misnomers. So that is what I want all of you to take home today. So, in the IPC section 88 in India, we do have this legal provision which says that nothing which is not intended to cause death is an offense by reason of any harm which it may cause, or be intended by the doer to cause, or be known by the doer to be likely to be the cause, to any person for whose benefit it is done in good faith and who has given a consent, whether expressed or implied, to suffer that harm or to take the risk of that harm. So this provision is there for the doctors, but unfortunately we have very little examples of, little practical examples of where this legal provision is being applied. So, physicians per se are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. And this is not what I am saying. It is the AMA Code of Medical Ethics of 2009. If you go through the AMA Code of Medical Ethics, you will see this in bold letters. We are not ethically obligated to deliver a care, okay, which by our professional judgment will not have a reasonable chance of benefiting my patients. Okay, so this is something we all need to understand today. And this is the law that actually is going to protect us. It is the medical ethics, Code of Medical Ethics, that is going to protect us. And having said this, we have to have sound professional knowledge of what we are dealing with. We have to follow evidence-based medicine at all times in every situation, so that somebody who asks a question, you are, you know how to answer. You know what are the evidence behind you doing that particular action. And at the same time, you are managing the emotions and the dynamics of the patient, the family, and the whole medical system. So your role as a palliative care physician, when you practice palliative care, is much, much more than a physician itself. It is not just giving medications or not just giving hospital rounds. It is much more than that. You have to first get yourself into that role, and then you'll have everything clear in your in your path. I mean, you will know how to react to that situation, what to do and what not to do. And believe me, this has helped me as a palliative physician. I have been a full-time palliative physician since a long time, and these particular things have actually helped me in the long run. So why do then doctors go for futile treatment? They are not oriented to cure. They are always oriented to curative treatment. When we go into the medical college, the only aim that we take as kids, 20 years of age, when we get into medicine, we know that we are going to be physicians who are going to cure the patient. So perhaps we will need to condition ourselves that cure is not the only thing that we need to learn. We also have to learn to accept, futility of treatment. We also need to learn that we cannot fight natural death. We cannot hold a person long time not to die, or not to go for a natural course of life. And of course, there are no training in palliative care, because palliative care came as a welcome change when the whole medical era shifted from, helping the patient relieve the sufferings to fighting death at all times. And that is why the relatives and the family actually run to a hospital whenever there is something wrong with the patient, and all they look up to is that this doctor or this hospital is going to bring back my patient to my family once again. So palliative care teaches us to accept death. Palliative care also empowers us to teach others to accept death. So this has to be there in every training. And very interestingly, very nicely, the 8COM or the attitude, medical ethics, and communication skills are now being taught in undergraduate courses also. I'm sure you all know about this. And then, of course, there is always a fear of being blamed for suboptimal treatment, as I think the previous student had already told us about, that family is there to blame you all the time. So there is a fear of that. So you can get rid of this fear only when you are sound in your knowledge. I would actually palliative care is not sitting and crying with the patient. It is not, holding hands and getting that through. It is active medicine. You must know, the therapeutic usage of silence, the therapeutic usage of communication. And you must know how to handle situations. So it makes you a much better person. It makes you a much well-equipped person when you know how to handle the situations. And you will be able to do only when you face these situations. So it is important that you plunge into such situations, try to take control of it, keep yourself calm, keep yourself as much poised as possible, and help the family members, help the patient out of the situation. Okay. And, I'm sure you will actually appreciate this in the long run when you practice it. Okay. So, of course, there has been ignorance about the guidelines for end-of-life care and the question of euthanasia. So when I talk about the end-of-life care policy, please go through this joint position statement of the Indian Society of Critical Care Medicine and the IAPC, which is the Indian Association of Palliative Care. They have outlined a 12-step, policy for palliative care, for end-of-life care. So you'll get to know many things when you do the class which is being lined up for end-of-life care. And at the same time, please go through these guidelines. They're actually going to help you and answer many questions that I am not able to ask as of now. So, when we talk about euthanasia, when we talk about terminality, there's something called killing and something called letting die. So we need to understand the distinction between what is killing and what is letting die, and in what circumstance, will it be morally justifiable for not to offer life-prolonging and life-sustaining treatments. And this is particularly important for those people who are working in the ICU. Okay, I'm sure there are anesthetists here. There are people who are, ICU specialists. So you must be facing this particular situation on a day-to-day basis, and it's important that you understand the difference between letting die and killing. So, as I said, it is a deliberate intervention undertaken with the express intention of ending a life to relieve intractable suffering. Of course, the intention is to relieve intractable suffering. That's true, but then you are actually killing that person. You are actually causing death by an intervention. And that is where we do not do euthanasia. We do not. Why? Because we know that the person is going to die. The person is having these kind of symptoms which are not being taken care of. But if we take care of these symptoms at the end of life, are we not giving relief to this patient? Okay. You will also learn something about palliative sedation. I'm not going into details about this, but then palliative sedation is also one intervention that is done in palliative care to take care of intractable suffering at the end of life. Intractable breathlessness, intractable, something like malignant bowel obstruction, where the patient is actually, is unable to pass urine or unable to take anything. There's no point in actually putting a Riles tube, doing 2 or 3 colostomies at the same time and letting the patient die in that situation. You are actually increasing the suffering of that particular patient. But then if we do a sedation for this patient, the patient can have relief of suffering. The patient will sleep throughout the sedation, but then as the principle of double effect, the patient may also die during the sedation. So there's something called do not resuscitate. And when we do not resuscitate, will it amount to euthanasia? We are using morphine and other drugs to relieve pain. Morphine and these kind of drugs, opioids, will have their own amount of side effects. Intravenous morphine might actually at one point of time may also cause respiratory depression. And there will be situations where respiratory depression might occur. And are we actually causing euthanasia by using that? So these questions, are very important questions. When we allow natural course of life to happen, are we actually doing euthanasia? So no, we are not doing like that. Please do not think like that. From today onwards, I request you not to think on these lines of euthanasia, because euthanasia, as I said, is something which is done deliberately and it's an active action. I would suggest all of you to please go through this particular book by Atul Gawande. He's I'm sure many of you might have read this book till now, by now. And he has actually given a beautiful picture of what happens at the end of life. So we cannot afford to die in the ICU. We cannot afford to spend these days in the ICU. We want everybody to be with us. And when we talk about statistics, you'll be surprised that 85% of healthcare spending in India is out of pocket. People, they would actually sell their land, their cattle, everything. They'll sell their gold, everything, and they will come for treatments which might result futile for their patients. 39 million Indians are becoming poorer per year due to rising healthcare costs. And it is not that we are saying, it is the Lancet who says that. Okay. Most related to aggressive medical interventions at the end of life, and has been rampant since the last 20 years. And we need to stop this. And unless and until we, pass on the principles of palliative care to everyone in the fraternity, may it be a doctor or a nurse or a social worker or whoever, in the medical team, they need to know about palliative care principles, because we need to put an end to the aggressive medical interventions that happen at the end of life. 300% increase in inpatient expenditure in the last 10 years. Can you imagine this? Tomorrow, if, my family doesn't know anything about what to do when I am in the end of life, I might also end up using all my finances, my savings in, getting myself a futile kind of a care. So this is the take-home message for today's class. There has to be respect of life in the background of ethical principles, and the acceptance of the ultimate inevitability of death. So these two things, please take them today and share it with your teammates, with your colleagues, people who are in the ICU. I request them specifically to share this thing with their own colleagues and people. Okay. So this is about today's class, and thank you so much for giving me a patient hearing. So over to you.
Madam.
Yes, I'll come. Yeah, just give me 2 minutes.
Thank you, Sanghamitra. I missed initial part of the presentation. Sanghamitra, there are a few questions in the chat. Will you be? Do you have time today to take up those questions?
I am. My team is actually waiting for a meeting. Please. I'll actually go through the questions.
I mean, there are a lot of questions. In the beginning, I've missed something. So, which I can recall is that if you withdraw support from the ventilator based on patient's relative's request, and the patient dies, what is it being called? I think it's regarding the euthanasia part. Someone has asked.
So, see, you're definitely going to have a class on withholding and.
Yes.
Going to have a class on withholding and withdrawing treatment, and maybe will it be a little premature to answer this question?
Yes, they just had 2-3 sessions on pain, so this will be definitely be covered in the.
Yes, because I really want you to hold on to this particular emotion and particular speed that you have taken today. Please be as inquisitive as you are today, till the day you actually come to know about this particular answer, because that is extremely important and extremely interesting. So I really don't want to raise the curtain now. So please wait for the right class to be taken by another lovely faculty. I'm sure Sridevi might have actually chosen somebody.
Sanghamitra, if you have meeting, I think it's okay. You can leave. I can take it from here.
Yes, I'm really sorry. I have to prematurely withdraw, but thank you so much for having me here. And maybe in the future, we can meet again. Yeah. Yes. Thank you so much. Thanks a lot, Sridevi. Yeah. Thank you so much. Bye. Bye.
Thank you, ma'am.
So I'll just take up a few questions that came in the beginning. I think there is a question from Dr. Roshan asking, does the patient's literacy limits the patient's autonomy? I think many times the literacy is not equivalent to the common sense. Many a times I've heard doctors telling that we didn't tell the diagnosis to the patient, we couldn't discuss because the patient was illiterate. That is not true. When you talk to them in words that they understand, generally they understand things in a better way. It's about how you present those things. Maybe you need to draw some pictures to make them understand that, okay, there is a tumor there, how it is happening, what is happening to that, what is that you are going to try through the surgery. Generally, people will understand that it is not at all related to patients' literacy. even talking about diagnosis or taking decisions or patient's autonomy. It is not at all related to literacy. That's what I have personally experienced, and that is what we tell everyone. Don't think that they are illiterate, so it's okay, or they won't understand what is going on. There is another question from Dr. Ocean again, is there any weightage for these ethical principles? I think it's very, very subjective. It will change from case to case. For example, in one patient, sometimes the autonomy overrides all other three principles. Sometimes we have to stick on to the autonomy. We may have to not to worry about the distributive justice a lot. So that is why we call it dilemma. We can't have a clear-cut answer to many of these dilemmas. So that is where your teamwork will play a major role, because sometimes we have our own notions about a particular thing. We may be one person who do not like NG tube when you are unable to feed. So that can actually cause bias in the decisions that we take. So it's very important to have the team along with you to have those discussions about what will be better, what do they think will be more of benefit for the patient, what do they think is going to harm the patient. So there is nothing that gives weightage to one particular ethical principle, but I think it changes from patient to patient and the situation. I will give midazolam to the intent to decrease rest. I think this was related to case scenario, Dr. Roshan. Yes, midazolam is very commonly used to control terminal agitation, terminal restlessness, sometimes for breathlessness. So it's a wonderful drug to be used, especially in many of these terminal restlessness patients. And there is one comment from Dr. Usha that midazolam can lead to death. I won't go much in detail about midazolam because, as I said, it will be touched upon in detail in end of life care. But still, when you are giving, like we heard in morphine, how morphine can be given in titrated doses. We are not giving some bolus dose like designed bolus dose. It is according to the patient's pain that we titrate morphine dose. The same way midazolam is gradually titrated. So for some patient will get good relief with 0.5 milligram of midazolam. Some patients we have gone up to 5 to 10 milligram of midazolam just to make them rest, to reduce the terminal restlessness. So it is very, very subjective, but if you are giving in titrated doses, midazolam may not proportionately give rise to death, or it may not lead to death. Just that you need to understand where you have to stop giving that titrated dose, what is the parameter that you are considering there. So I think these were the questions in the chat. And withdrawing and withholding life support is a major topic which will be covered in detail by the experts who have actually worked in that field to make a consensus statement in withholding and withdrawing life support. So just in a nutshell, if you withhold or withdraw a futile treatment, we cannot call it euthanasia. Euthanasia is something that you need to do actively. It cannot just happen like something like very passively. You are stopping a treatment, or you are not giving a treatment which you know that is futile. So you're basically following a non-maleficence. You know that this is an advanced cancer. The patient may not withstand these kind of inotropic drugs. You know that, so you're withholding that. So that is something that we will discuss in detail for sure, but that is very different from euthanasia. Yes, Dr. Roshan, I think all the palliative care people in the country or in the world is totally against euthanasia. If someone is asking or pleading for death, there will be definitely something that is causing the suffering. So we start by asking them, what made you ask that question? It is usually intolerable pain or any symptoms. They don't know how to live their life because they are disabled right now. So there are usually these requests come from intolerable, serious health-related suffering. So our aim is to reduce the health-related suffering so that patients may not have to plead for euthanasia. This is a very commonly asked request in our team. We hear it like on a daily basis. Doctor, please give some medicine and kill me. So they start from there, and we help them to reach a state where they feel like they want to live somehow in a meaningful way. Even though the days are less, the quality of life will be better. So any palliative care doctors or any team members will be totally against euthanasia, and we are moving to court to remove that term passive euthanasia because it is very confusing. It has to be active. Euthanasia means you have to inject something. It has to be active. Cannot be a passive. But this term is creating a lot of ambiguity in the law as well. So we are moving, or we have already done a lot of work to withdraw that term called passive euthanasia from the legal context. Yes, Dr. Parul, this is again another request that we get very commonly. Quadriplegic, there is no one to take care of me. I'm totally dependent on my elderly mother, as we saw in the first day. I can't do anything on my own. Why don't you just kill me? So, what about helping them to find some meaning in their life? Like right now, we have at least a few quadriplegic or paraplegic patients admitted downstairs. Whatever simple things that makes them feel meaningful. It might be very, very small thing for them. Holding a spoon on their own might be something really big. We all take it for granted, right? You can hold the spoon, you can eat with your hands, but sometimes customizing a spoon so that they can hold the spoon and have a spoonful on their own, that gives a lot of meaning to them. So finding that particular activity or anything that gives them meaning, or maybe they may want to talk to other patients. Some of them really want to talk about their or share their experience with the other patients or with the team. That's absolutely fine. There is someone to listen to me. That gives them a lot of relief. So, majority of the patients who come with the request of please kill me, doctor, generally, I've not seen any of them still there telling that please kill me, even after months or weeks. So, I think that is something that we need to identify and make them to identify the thing that can make their life meaningful. Not an easy job. It's a teamwork. It will take a lot of consultations and conversations. No one would want to tell you that what makes their life meaningful in 1 or 2 visits, right? So it's the teamwork. They may connect with one particular member of the team. Generally, it can be a social worker, it can be a doctor, it can be a volunteer. So through that, we need to have multiple conversations so that we'll understand what is it that is so important for this particular patient. I understand from the chats that there were a lot of discussions happening in today's session, but that's quite good to see that, because only through discussions we all will learn than just giving a lecture. Are there any other questions in the chat that was unanswered? I'm happy to take it up. Or any new questions that you want to discuss? Today we do not have a case presentation. So if there are no more questions, we can wind up today's session by this. And send the feedback link in the chat. Please request everyone to give us feedback so that we can improve the sessions later. Yes, Dr. Jalash, please.
Good evening, ma'am. That was a very nice presentation by the ma'am, and each and everything has been taken in so much of a detail. But what I probably get from this session is actually here we are not learning what we should do. It is actually how we should approach the case. And the part of country in which I am practicing right now, we are actually not treating only the patient. here we are treating his or her whole family, her relatives, and so many other persons also. So my question is that if we under one, then if we are offering all those treatments which can be given either futile or non-futile, so that can be considered as medical negligence. And what if we overtreat the patient, like just to safeguard us? Uh, in some of our cases, even the local MLAs, MPs, and all those politicians, they used to call either directly to us or our seniors, and then they will say, "Oh, shift that patient to the ICU."
Yeah.
Yes, there is no possibility. The patient is not going to respond to any treatment. Oh, I am not here to listen to all those things. You just simply have to transfer that patient to the ICU and just occupy that bed.
Yes, yes.
So
Totally
this is the common
understand,
practice.
Dr. Jalaj. I think it's same. It's not very different in our place also. I think in a normal hospital setting, all these kind of things happen. We have to treat the whole village, not just the patient. I totally understand that. But I think it's all about the I understand first of all, I would like to acknowledge that it is not an easy job. It may not work all the time, but it is very important to have multiple discussions, which you will learn in detail in communication skills again, which is the upcoming session. You will have to tell the same thing to, there will be multiple decision makers. Today one uncle will tell, okay, don't put in ventilator. Next day another person will come and tell you, please put on ventilator, and they will end up in having a fight. But there are things are changing in many parts of the country where what we do here is like we call a family meeting. First of all, understand who is the primary decision maker. Is it that the local leader, or is it the wife, is it the son, or is it some relative sitting somewhere else in the world? So understand who is the decision maker. Do not repeat the same thing like every time you talk to one person today, again tomorrow you have to spend half an hour with another person, and this person will tell something else. The way they listen or understand is different, so it's always good to have the family meeting. So another setting where I worked in the ICU, we'll have ICU doctor, the palliative care team, and the whole decision makers in the family sitting in the same room and having the conversation and document it. What do they understand, what has been discussed? They cannot take decision in a day, still they will tell you, please put in an ICU. Again, have the conversation next day, okay, now the patient is in ICU, these are the drugs. So there we have to step down or not to escalate some treatment. Now we have already started, but there is a possibility that you can decide not to escalate further. So this conversation can continue everyday basis, and there are some people still they want to stick on to that unnecessary interventions, but many a times majority these conversations would work. And documentation, proper documentation of what has been discussed in every session, who all were present, what did this person tell. So as a team, one person will be actually writing down the notes, like what all things were discussed. So the uncle was of opinion of this, but then this person was telling this, so everything will be documented. Gradually they will see the patient suffering. At least after that they generally tend to agree that okay, this is enough, do not escalate further. Now we do understand. So it's not an easy job. Sometimes it may not work also, not all the time this will work. We also have a lot of failures like in between. We can't solve every problem, but this is the way we approach it, having a family meeting together and keep on having these conversations on a daily basis. Thank you, Dr. Jalash, for that question. I think it's the same everywhere in the country. Yeah, so again, Dr. Mrinal is asking about the stigma. Yeah, very true. How can my neighbors will ask me, why didn't you take your father to an ICU? What kind of children you are? They will ask the social, I think they expect someone to be in hospital when they are dying. So I think again that's about preparing the loved ones, because they are already traumatized by this losing their loved one on one side, and again they have to face these questions from the relatives. So it's very important to support the primary caregiver. If they come into an acceptance, then they can probably overcome that, but they need continued support. It's a very challenging time for them if they decide not to go for aggressive treatment, because everyone will ask, they will comment, even after the death they will come and see they haven't even taken to a good hospital. So that's about giving confidence to the caregiver and to support them as much as possible from our side, not to make them feel guilty, and make them feel why they choose that decision, for whom they chose that decision. I'm sure that all these things will be covered in many sessions on end of life care or in communication skills, but I'm just touching upon what is generally being done. Yeah. Thank you. Thank you so much, everyone, for Morley. Yes, Dr. Roshan Kumar is asking about the documentation of CPR. Like in our country, even if I write that I don't want to be resuscitated, I think my doctor can still decide to resuscitate me. No one is going to sue the doctor, probably. But yeah, again, Dr. Roshan Kumar, I'll postpone that question for the end of life care, because the documentation, what is to be written, what is the legal validity of that, is covered in detail. Thank you so much, everyone, for the questions. And Dr. Jalaj, you brought a very important point. This is not about giving answers to the question. This is about telling you how to approach this particular situation, and how to have that palliative care approach, or person-centered approach, I must say, not just palliative care. It can happen to any, it should be there with every specialty. So more patient-centered or family-centered approach for each patient is what we are trying to do. Very, very truly pointed out. It's not giving solutions, this is right or this is wrong. It's about changing the way that we think about the patient. Thank you so much, everyone. We'll see you next day with another wonderful discussion and session.